All right, so we're in the home stretch, exciting talk so far, some interesting case-based discussions to follow. But first, we're truly honored to have Kim Eagle give his talk and really talk about his experience and his view over the past 25 years. Dr. Eagle is a Hewlett Professor of Internal Medicine and Director of the Cardiovascular Center at University of Michigan Health System. He's published likely over 500 articles, given several hundred talks. One of his greatest contributions, at least in my opinion, has been, being the founding father of IRAD and really helping us learn about acute aortic dissection. Kim has been an outstanding partner for us over time and really an advocate for patients with thoracic aortic disease. Thank you, Kim. Honored to have you here.
Great. Thank you so much for the introduction. Can you hear me fine? Is the audio okay?
We can hear you.
Okay, great. Well, it's a pleasure for me to participate in this conference, and I applaud you for really what looks to be an outstanding conference on a lifetime approach to aortic disease. And I've been fascinated by acute aortic syndromes for 40 years, and I still continue to believe that if you've seen one, you've seen one, because they're all different and they're all potentially lethal, and we can't do enough in terms of team-based research, care, and education to fight to do a better job in this particular area. So the work I'm going to present today is just maybe a dozen key points, knowledge nuggets for you that we've accrued from the International Registry of Aortic Dissection over 25 years. And of course, this is not my work. It's the work of literally dozens and dozens and dozens of people like the faculty at Pittsburgh and others who have taken on this labor of love to try to understand dissection better. The next slide has my disclosures. And obviously, without support, you can't do this kind of research. And I'm incredibly grateful for all of the investments made by both foundational, private donors, et cetera, who have made this work possible. The next slide. So, many years ago, we thought about dissection not only anatomically, but also according to time. And for years, we accepted as a definition that an acute dissection was anything within 2 weeks of symptom onset. And these two panels illustrate findings from IRAD, which I believe suggest that perhaps we should use a different nomenclature for time. And I would argue the lower offering here on the right, the IRAD offering, suggests that the mortality in that first 24 hours is a hyperacute period where we want to quickly assess and operate, particularly on type A, and probably do endovascular therapy if we can in complicated type B. After 1 day, we call that acute period day 2 to 7, where we see further attrition, particularly if patients with type A are not operated. And then from day 8 to 30, we see additional mortality. And after day 30, things really flatten out. This is sort of Darwinian, isn't it? That if you're able to survive a dissection for 30 days, there's a pretty good chance you're going to survive a long time. Obviously, we can't take the chance with our patients, but it is an interesting observation. The next slide illustrates, I think, something that is very much underappreciated, and that is that prior heart surgery is a risk factor for acute aortic dissection. Now, this probably has many facets, doesn't it? But in this study this is a group of, 8,000 patients, roughly 20%, almost 20%, had a history of prior heart surgery. Some of these, of course, were perhaps aortic valve replacements in a patient that had a bicuspid-related aortopathy that wasn't severe at the time. But I think also we should pay attention to the notion that when we cross-clamp an aorta or when we put in vein grafts, we potentially weaken a segment of that aorta. And in the presence of other risk factors, like, say, hypertension or smoking or what have you, that is an aorta that previously has been damaged and may predispose the patient to a future dissection. Furthermore, we know that patients who've had a sternotomy tend to have less pain perception with their dissection, and we have to pay attention to this as well. A patient with prior thoracotomy may present more atypically than a person who's not had their chest operated on before. The next slide illustrates another important finding. I love this quote. This is by Paul Dudley White. Paul White was the chief of cardiology at Mass General, where I trained many, many years ago. And in his single author textbook in 1944, he wrote this about acute aortic dissection. Pain attending the splitting of the aortic wall is usually excruciating and extensive, radiating the thorax, front or back, through the chest, down the back, and even into the thighs or up into the neck. But the key phrase, which I think we can't emphasize enough, is the pain in the thorax or back comes suddenly at its maximum. Patients who dissect their aorta often will have a photographic memory of exactly where they were, what they were doing when it started. Ironically, if the disease is missed and they come to UPMC or University of Michigan a day or two later, their pain may be entirely gone. In fact, it's often gone. And if we don't go back to that original historical clue, please tell me, sir, how did your pain start? We miss an absolute key to making this diagnosis at the bedside. And the next slide shows this in terms of the IRAD experience. If you look at the various types of pain features, abrupt onset is the most sensitive, about 85%. And most of the rest of the patients have fainted. And you see syncope is also very common, especially in type A, as high as 17%. So these two, syncope, unexplained, and particularly the abrupt, instantaneous onset of chest or back pain, we should always be thinking about this could be a dissection. And the disarming feature that the pain can wane or go away completely creates this sort of false assurance that, oh, maybe things aren't so concerning now. Go back to the start. Please, ma'am, tell me how your pain began. Next slide. One of the most sobering things that we've discovered in IRAD is that when we look at the size of aortas that have come to diagnosis, and this is, of course, after the aorta has torn. So when you look at how much an aorta grows immediately after dissection, our studies suggest that compared to a week ago to today, the aorta will grow typically 3 or 4 millimeters. They don't just blow up like a balloon. That hematoma in the wall creates expansion, but it's usually not massive. So if you look at type A dissection patients and ask the question, what percent of them had an aorta that we would have operated on had we known they had an aortopathy? The answer is it's not a high percent. This slide, I think, illustrates that fact. You see that more than half the patients, 60%, have an aorta that's less than 5.5 centimeters in diameter, and not a small number have aortas that are quite small and sometimes normal. This, of course, explains why the chest X-ray doesn't show a wide mediastinum, why the aorta on echo doesn't look so very large. And it gets at this myth that dissections happen only in aneurysms, and that's not true at all. Aortas that are prone to dissect may not necessarily be prone to grow slowly over time. So this is a very important and sobering fact, and certainly calls for more science as we try to get better with identifying patients at risk. Next slide. Over time, IRAD, because it's a longitudinal registry, has given us the golden opportunity to ask the question, how are we doing? And this study looks at 3 different tertiles of the IRAD experience. And on the left, you see that the number of patients with type A dissection who did not get surgery has steadily dropped over time. Courageous surgeons taking on even higher risk patients, older patients, to give them their best chance. And you see this has led to an overall improvement in mortality in the IRAD experience, which I think illustrates the fact that we are doing better and better, both with diagnosis and certainly with treatment. The next slide shows what happens if you operate on type A patients in the IRAD experience. And, we saw an operative mortality early on that was in the 18 to 20% range. And now in good centers like UPMC, Michigan, and others, that number is probably well below 10%. This, of course, is all about team-based care, excellent diagnostics, excellent perioperative management, superb anesthesia, better operative techniques, better postoperative strategies, etc. But it is gratifying to see that we're making steady progress in a disease that is highly lethal if we don't attack it perfectly. The next slide illustrates the issue of age. I remember when I was a cardiology fellow 100 years ago, it was a challenge to talk our cardiac surgeons into taking on a patient who was 70 years old. And at that time, 70 was considered to be out of bounds, perhaps, for the possibility of survival of a patient with type A dissection. And as we look at the IRAD experience over time, what is very clear is that we're doing much better in patients who are 70, 75, 80. And if you ask the question, when do the curves cross? When does medical equal surgical mortality in type A? I can't give you a firm answer, but this data from IRAD suggests that at least out until 85 in a patient who otherwise has what you would appear to be a reasonable shot, that surgery is as good and probably better than medical therapy for this lethal type of disease, type A dissection. The next slide. Increasingly, the IRAD experience has allowed us to ask the question, how do we stratify risk better? And this slide illustrates the fact that as we look at the number of beds that are malperfused, this is extraordinarily important in predicting in-hospital mortality seen on the left. If you have leg ischemia or bowel ischemia or arm ischemia or brain ischemia, as you tick off organ systems that have evidence of malperfusion, you see the mortality in hospital goes down, 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 down. If somehow in great hands the patient is allowed to survive, that really then flattens out. If you can get them through that 30-day window where you're simply trying to survive and have key organs survive, then of course the risk stratification changes. And there's, like Darwin said, there's nothing like survival to predict survival. And some of these patients go through just amazing experiences and complications and somehow emerge on the far side. And many of them then will live long and healthy and productive lives after that. The next slide. We've been debating about the role of endovascular therapy for type B dissection for a long time. And the INSTEAD trial, which I think you've probably heard about, and others, limited trials suggest that for complicated type B dissection, certainly endovascular therapy offers a nice option, especially as opposed to open surgery where further malperfusion occurs if you cross-clamp the aorta. In the IRAD experience, when we looked at endovascular therapy for type B, we saw that the curves were relatively similar to medical therapy early on, but by year 3, 4, 5, we started to see a divergence, and this might be due to the ability to reverse remodel the distal aorta, get rid of the false channel, and see more stability. One of your faculty, Firas Musa, has submitted an NIH grant to study this along with many of the members of this panel. That trial would be, I believe, 800 patients randomized to endovascular therapy or best medical therapy plus endovascular in one group, medical only in the other, to see whether or not endovascular therapy should be more routinely applied. Currently, we don't have that information, and for most of us, we're still looking for the complicated patient or other high-risk features to define the appropriate use of endovascular therapy. Next slide. We've been searching for a biomarker too, and the IRAD experience suggests that we do have a very sensitive biomarker for acute aortic dissection, and it is D-dimer. When the aorta tears, there is intense clotting, typically in the false channel or around the aorta. This leads to a sudden increase in the D-dimer, and this is a study we published quite many years ago, looking at the levels of D-dimer in dissection. You see that on the left, MI, angina, PE. And generally, in acute aortic syndromes, D-dimer is massively elevated, and it's rarely not. The only patients that I have seen who have not had that had a limited intramural hematoma, and by far, we think 95 to 98% of patients with acute aortic dissection do have elevations of D-dimer. Obviously, the problem here then is the specificity. We know that D-dimer can be elevated in acute pulmonary embolism. It can be elevated in acute MI complicated by LV thrombus and other conditions. But if you're looking for a sensitive biomarker to put into your lexicon in ER management, we have one. It's D-dimer. And the next slide, I think, illustrates how some have used this in a patient who is at lower risk, where the chest X-ray, et cetera, isn't dramatic. We might consider using D-dimer as a sensitive test to try to rule out dissection in patients that might be in the lower probability range. Let's go to the next slide. We've also realized over the years that dynamic imaging and changes in imaging over time are important. This particular study was a look at what happens to the distal aorta in type B. And we discovered in IRAD that if you partially thrombose the distal false channel in type B dissection, we think that you create sort of a blind loop where there's pressure into the false channel, but no exit. And this increase in pressure elevates the diastolic pressure in the false channel, and we think leads to expansion and rupture. And we were able to show this both in an experimental model in our School of Engineering, as well as in the IRAD survival statistics shown here from a New England Journal paper dated some years ago. Next slide. I would submit to you that I think we've paid far too little attention to survivorship. How do patients do after we go through the flurry of medical challenges that we face with them and their families acutely? How are they mentally? How do they function as citizens in our society? How do they function as a partner? This study from our own IRAD experience at Michigan shows that dissection survivors, 40% have been disabled. Almost 3/4 admitted to us that they stopped having sexual relations forever because they were afraid. Anxiety and depression are seen in about 1/3. And most of them, the vast majority, do not feel like we as providers were anywhere close to being adequate in helping to understand how they can live. What can they do? What should they watch for, etc. I hope that the next decade of work in dissection addresses many of these survivorship issues, including exercise, sexual performance, mental health, etc. We need to do a better job. But once they've survived, we need to help them survive better by having science and education that can allow them to understand what's possible. Next slide. And when you ask patients who have aortic dissection what kind of information they think is important, over half of them say, I want my doctors to have the right information to give me so I know what to do. Of course, they're interested in genetic testing and how that can influence and improve diagnostics. They want to know what kind of exercise can they do? Is it safe? And for subacute dissection, when and if should they have surgery? So these are the questions our patients and families are asking. These are the questions that we as providers and scientists need to address. Next slide. It's really amazing to think back. I think the first documented case in the literature of dissection was from 1760, the death of King George II. And here we are, 300 years later, and still it seems like such a frontier. But we're making progress. I think the IRAD experience gives us an example of that in terms of watching how care evolves and how improvement occurs gradually, one patient, one center, one surgeon at a time. Next slide. Charcot said, disease is very old and nothing about it has changed. It's we who change as we learn to recognize what was formerly imperceptible. I believe that the next decade will see significant evolution, if not revolution, in the way we use genetics, in the way we use imaging, in the way we approach survivorship, and hopefully in additional tools that we can use to more non-invasively attack catastrophes of the aorta over these next years. Next slide. How could I possibly end without thanking the IRAD investigators, people like Ibrahim and others? We have 60 active centers in IRAD today, many more coming, and I am incredibly grateful not only for the work that we've done together, but for the friendships that we've forged that have allowed us, I think, to grow in our profession and hopefully make a difference in the world in which we live, that is attacking aortic disease. The next slide is a shout out to the colleagues I have at Michigan. I've been at University of Michigan for quite a long time, since 1994. I'm surrounded by talent, whether it's surgical, imaging, cardiology, genetics, et cetera. And my journey would not be nearly as fulfilling if I didn't have this amazing type of group of people to work with and help support. Next slide. You know, Osler had a lot of great sayings, but I like this one a lot. There's no disease more conducive to clinical humility than aneurysm of the aorta. If you've seen one, you've seen one. They're all a little different. They all challenge our brains, our thinking, our past experiences. And I continue to be absolutely fascinated by this set of problems. I want to thank you again for allowing me to speak to you today and look forward to joining the panel discussion in a little while. Thank you.